Hello and welcome to the Nutri-Round Webinar presented to you by the International Clinical Nutrition section of the American Society of Parenteral and Enteral Nutrition. I'm Adrienne Speedy. I am a dietitian based in New Zealand. So for me, it's 10 p.m., but welcome to you all across the world. We have our wonderful presenters today based in Brazil, and I'm sure you're all throughout the time zones around the world. So thank you for joining us. Today we're going to have a great session all about home parenteral nutrition. We'll have our two presenters and then enough time for questions. So please use the comments box to put through any questions, and then we will address them after our two presenters. So without further ado, we will start. I'd like to introduce first Maria Paula Coelho, oh my goodness, and I'm going to have to forgive, my Portuguese is not good. But Maria has been a pediatric surgeon since 2004 and is focused on liver transplant and hepatobiliary surgery since then, with a clinical fellowship in liver and intestinal transplantation at the Birmingham Children's Hospital in the UK from 2015 to 2016, and she currently is the head of intestinal rehabilitation at the Sambara Children's Hospital in São Paulo, Brazil, and also the Aspen International Clinical Nutrition section chair-elect for 2024. So I'd like to welcome you, Maria, for your session on planning and training for home parenteral nutrition.
Thank you, Adrienne, very much for this kind presentation. So, can you see my screen now? So, Hello, everyone. Good morning for those who are here in this side of the planet, and good evening, Adrienne. It's an honor and a pleasure to be here today talking about transition to home PN. I have no disclosure related to this topic. As you now already know, I work with children, so I'll be mainly talking about home PN for pediatric patients. And I divided this presentation in 4 topics. So we're going to go through intestinal failure and nutritional support in the beginning, and then intestinal rehabilitation programs. And then we are going to talk about planning and home PN support. So intestinal failure is a rare condition, and sometimes it's named in different ways in literature. It's very important for us to be capable to speak the same language. So here are some definitions released from ASPEN in 1222. So pediatric intestinal failure is a reduction of functional intestinal mass below which can sustain life, resulting in a dependence of supplemental parenteral support for a minimum of 60 days within a 74 consecutive day interval. And short bowel syndrome, that is the most frequent cause for intestinal failure, is the development of intestinal failure secondary to loss of small bowel, either from congenital absence or following surgical resection. And for example, in necrotizing enterocolitis or intestinal atresia and gastroschisis. And ultra short bowel syndrome is the development of intestinal failure following significant small bowel resection, resulting in a reduced residual small bowel length that is below 10% of expected. And then there's an important question: what is the expected for the kid? So in 2009, the Sick Kids released a very interesting article where they show studying 108 laparotomies in children with no GI malformation and well-nourished. How much is the length for that height and for that weight and for that gestational age? So we do have parameters to see what was expected and then to measure how much is it now. So, many patients does not have a short bowel, but it still have intestinal failure. So we have the motility disorders like myopathies and neuropathies, for example, in intestinal pseudoobstruction or intestinal aganglionosis. We also have the congenital enteropathies, so like protein-losing enteropathies or primary intestinal lymphangiectasias. But then we also have 14% of patients with non-digestive intestinal failure. So I do not expect you to read this, but actually they are neuroevolutive disorders, they are primary immunodeficiencies, they are GVHD or pancreatic disease or even congenital heart defects that lead those patients to intestinal failure, sometimes temporarily, sometimes a more long period of intestinal failure. So saying that, we are moving to nutritional support. So when we have a patient in that situation, we need to plan what is the best nutritional support we can offer the kid. So remember, children are not adults. They need to grow and to develop. So let's talk about some definitions here. So parenteral nutrition is one kind of parenteral support, and parenteral support are fluids IV that may contain a combination of macronutrients, electrolytes, vitamins, trace elements, and it can be used to provide full estimated needs, so fully on parenteral support, or it's associated with enteral nutrition that's more common. And what we call enteral support. So it's the provision of sufficient nutrition and fluids through the intestinal tract to facilitate appropriate growth and hydration with or without parenteral support or nutrition. So we can use it when we wean off PN, but usually we are using both together while we stimulate this GI tract to improve and then wean off the PN. And what's our goal? Our goal is to reach enteral autonomy. So that is the maintenance of normal growth and hydration status by means of enteral support without the use of parenteral support for a period of 3 or more months. So, and then we have what we call intestinal rehabilitation programs. So why is that so important? So an interdisciplinary team that works in a collaborative way to provide not only a tailored nutrition for each patient, but also deal with the different aspects of their needs, working together to prevent, to recognize precautiously, and treat acute complications and chronic comorbidities. So it's already in the literature for some time now that is demonstrated the importance of intestinal rehabilitation programs. It is shown that we have a positive impact on survival. So saying that if your center does not have an intestinal rehabilitation program, but does have patients with intestinal failure, the recommendation is or to transfer the care or to be closely in touch with teams of intestinal rehab for consultation. Otherwise, you won't be giving to your patient the best chance for her or him to improve and survive with a good quality of life. And how are those RPs formed? So there are recommendations for essential participants like we must have, and also for key participants. The essentials should be available in a routine basis. So they are pediatric gastroenterologists, they are pediatric surgeons, PN physicians, and for sure, sometimes one physician or one team member plays more than one role. We need dietitian, we need nurse coordinator, we need someone to administrate the program. We have pharmacists and social work. This is the core of the program. They need to be available every day. And then we have the key members, and they are very, very important. So you have to be able to get in touch and ask for consultation for this more spread part of the team. So we need transplant experts to understand what's the timing for the patient. We should refer for transplant or not. We need radiology, interventional radiologists, and all kinds of specialists from nephrology to infection disease. doctors and also nurses for different purposes. So we need a practitioner, we need for general care, someone is looking for vaccination, for example. We need specialized nurses because they have stomach problems, they have PICC lines, and then we need nurses for the home care, and usually they are a separate team of nurses. Also, we need data administrator and a research team. This is fantastic when you can have, because you put your data together and then you can publish, so you can share with everyone what you're doing. And you need speech and language therapists, occupational therapy, feeding therapy for those kids. Also, you need clinical psychologists and child life specialists. So we say the more the better. But as long as you really work as a team, so you have team meetings, discussions, inpatient and outpatient clinics, home care. So you have to work together. And now we are going to talk about two very important concepts for dealing with this long-term complex problem. So we have intestinal rehabilitation programs, and we can manage the patient better. So we have this one-stop shop concept where we should no longer send the patient to different places for different appointments or exams. We should change things at the hospital or at the outpatient clinic environment to provide the patient all they need in one single place. So when the patient comes to the clinic, he or she will be able to go to get all they need at once. So they can do the x-ray or the ultrasounds, they can do the blood tests, and they can see the team they need for that appointment. That would prevent days off school. That would prevent parents of missing days at work. They save money for traveling because many patients come from another state, for example. And that will also improve the communication and simplify their lives. And their lives are already very complicated. We can do better. And another thing is telehealth support. So we have a saying here that's remotely whenever it's possible, face-to-face when needed. So it's important to use technology, and we learn a lot with the COVID that we have. We learn how to use technology to give telehealth support. So we usually, after sending the patient home, we do that weekly right after, and then we see face-to-face monthly in the beginning. And our patients, you can see here in the map, they are too far from us sometimes. The country is too big. So we learn how to do that, to put the families, the local team, and our team together, moving the knowledge and not the patient whenever it's possible. So here in this picture, you can see in this screen in the back, we can see the local team participating in the appointment, and you can see our nurse. She's collecting the blood and changing the dressing at the same time. So let's talk about planning. So we are doing a care for life. So we have to plan the entire journey of the patient. They are going to be with us for a long period. We are going to be there at the acute event. Not always. Sometimes the patient is transferred from another hospital to us, but they may be very severely sick and unstable in the beginning, and we have to be there to take some difficult choices and procedures in the beginning, choosing multiple devices, and then starting PN. And we are going to be there to win off PN if we're lucky and everything goes well. We'll be together also when they are experience different feeding devices, when they're learning to eat, or even sometimes for the first time. And then we're going to be there when they're sending them home, when they're trying to adapt for this new social life. They will get to school and then maybe traveling, doing sports. They have many doubts about what they can or cannot do. And then we are going to be there also to support for their complications. We are going to have them. We are going to have the acute complications and also chronic ones. And then we're going to help them to choose what's the best choice for them at that point. And actually, we're going to also be there to transition them for the adult care, because we are pediatrics. So saying that, we have to be putting the patient in the center of the care always. And doing that, we are actually using a different concept that's called healthcare design. We are going to be planning every touch point of the patient and the family with the health system. And we are also planning the other things that we never imagined, like school. We're going to be talking to teachers. We are going to be planning traveling. We're going to be planning days off PM if it's possible. So doing that with them, together with them, the family is part of the team. We are going to have a good engagement and also a better quality of life for them. So one question is the patient ready to go home? So it's important to understand how stable is the patient, and is she or he well enough to continue the treatment at home? In the beginning of the process, right after the main event, we are dealing with many challenges. So we're going to be in a cardiovascular instability moment. We're going to be dealing with septic shocks and electrolyte and fluid imbalances, frequently needing IV corrections, and dealing with high outputs from nasogastric tubes or ostomies. And we have to consider if we are already in a more stable phase. So are we introducing oral feeds or enteral feeds? Are we already cycling PM? Is it possible to cycle PM? Are we needing less and less frequent blood tests? Because actually what we are asking here is, how manageable is the patient if we send him home now? Is he ready for that? And another important thing is venous access. So does the patient have a safe venous access? And initially, we have too many problems running at the same time. So we need double or even triple lumen lines for short time period. But as soon as possible, we should consider to change to a long-term tunnel lines. In the hospital, we have specialized nurses for PICC. So we usually start with PICC lines, and we know that the less lumens we have, the fewer manipulations we're going to have at the central line. So we decrease the risk of infection. And there are also, in pediatrics mainly, important things to think about. Where is the exit side of this line? It's easy to do the dressing there. So sometimes we put a central line in the neck, but doing the dress in the neck, it's very challenging in a kid. So can you do better? So, and for PICC line, when we talk about sending home with PICC, it's possible, but isn't it better to have arms free? Shouldn't we do like a Broviac or another tunnel central line to make their lives easier? And also, I put the port here because it is a possibility to use ports, but ports are not developed to be accessed and de-accessed in a daily basis. So we can have we can add some risks on doing that. So we usually consider ports for adolescents that ask for it because body image, and those patients that really, really love to swim and they ask for some device that they could swim, or patients that use the line few days in a week. That's also a possibility. So what about planning? Is home ready for the patient? So who is responsible for that? Is your RP still involved? So the home environment need to be evaluated. Does this family have everything she needs at home? Is the caregivers trained? And also the social support is good at that family? And the local team is prepared. Who is the local team? Are they going to work well together with you? Can they be prepared? Because they can be not prepared. So attention in some very important things. Who will provide the supplies? Who will prescribe the PN? Who will provide the delivery? You need to clarify who is responsible for what. And when we talk about home PN support, logistics is very important. So who is coordinating and who is funding? Everyone is following the same protocol. PN, it needs to be prescribed, prepared, delivered, installed, and maybe different players are doing that. Checklist for supplies, it's a very useful thing. And we maybe have too many players, but we still one team. So work together. And the local hospital for emergencies need to be aware of that patient. So there are many problems that can be solved at home if you have a great team. Here I'm showing you just one of our checklists for everything. So here for parenteral nutrition, there's a list of what you need or how many things you need for that and what you're using for. So every patient should have a list. So diet is a super important issue. Parents want to know when and how they're going to feed them. So your dietitian should have a map for them for that. And also you're sending the kids to school. So this is a nice thing that one of the home care units prepare for one of our patients. Are they going to have lunch or snacks? The children eat by mouth or use a tube? Who is training the tube feeding at school? Does the child have an emergency kit? That's very important. Are they prepared to act? Does the other kids know and understand about these child devices? And just talking about complications. You can try to prevent and be prepared, but sometimes it's very challenging. So you're going to have fluid and electrolyte disturbance sometimes. We're talking about kids. They have respiratory and gastroenteritis from time to time, and you have to prepare to act at home. It's not a problem. We have to deal with shortage, and we have to be aware of catheter events like thrombosis, infections, or even displacement of the line. And miscommunication, it's something very, very important. So be clear what you're talking and who you're talking and who is responsible for what. Here are just some nightmare pictures. Here is a granuloma from a gastrostomy. This is also a granuloma, but this is the central line. So look at the skin, and this is the granuloma here. And also, this is a peak line in a patient at home. So you can see the rush. And you can see that the peak have been moving around. So it's probably not central anymore. And this is the patient with a port. So look at this. She is receiving fluids, but the port is exposed here. This is a problem with ostomies in a very, very small patient. And this is an interesting needleless device where the patient had more than one staphylococcus infections, and we couldn't find out what was going on. And after the second one in a row, we asked mom to film and take pictures of everything at home, and we found out that they were not changing this device very frequently because they are not receiving them enough. And actually, this was a not very good one, so they could not flush properly. So after we changed it, she never had an infection again. So be creative. Here is my bibliography, if you want it. This is our team here in Brazil, so I thank all the team for all we've been doing here. And also, this is our ICNS family. So join us. It's a pleasure to be here. And this is my contact. So with that, I thank you all.
Well, thank you, Maria. That was wonderful. Not a long time to talk about a very complicated and the details really matter when it comes to planning and training for home parental nutrition. So I appreciate that. Now, I believe that we'll move straight on to Nathália and get her perspective, and then we'll open up for some questions following her presentation. So Nathália Castro is a nurse who graduated from the Federal University of Sao Paulo as a specialist in child and adolescent health from the from a hospital in Brazil. I'm just going to say that.
Don't worry.
I'm really sorry. She works at the Sabara Children's Hospital as a senior nurse leader in the inpatient unit, and she is a nurse on their pediatric intestinal rehabilitation program. So she's going to chat to us today about the role of the nurse and the nurse team in the transition to home parental nutrition. So welcome and thank you. And I'm sorry again.
Thank you, Adrienne. Let me put this presentation here. First of all, I would like to thank the organization committee of the event, Carol, Diego, and Dr. Maria Paula for the invitation. It's an honor to be here today, sharing knowledge and talking about this very important topic. A little curious about me, is my first time doing a presentation in English, so I'm a little nervous. But if you guys have any questions during the presentation, just let me know. Talking a little about me, currently I'm the senior nurse leader of the pediatric inpatient units at Sabara's Children's Hospital and a member of PADI team. I always wanted to work with pediatrics, and that's why my academic training was focused on this. In 2021, I was promoted and had the opportunity to join the management and leadership area where I find myself so far. I would like to present our schedule for the day. We will start by presenting our health service, our reality, and we will continue with the criteria for the hospitalization with a home care company. Think always in a pediatric patient using a parenteral nutrition together with family participation and home care company. As well, this nurse roles as an educator. We went by showing how we do in practice in our institution, and finally, our conclusions. We are private hospital located in São Paulo, exclusively pediatric and a reference for all Brazil. We serve the most diverse types of diagnoses and complexities, in addition to having a structure to develop for the care of patients with intestinal failure, with dedicated units and a qualified team to care for this public. Among our patients with intestinal failure, most are affected by short bowel syndrome, like intestinal atresia, gastroschisis, volvulus, and neck. One of our differentials was the implementation of a program made the care of patients diagnosed with intestinal failure, known as PADI team, like a pediatric intestinal rehabilitation program. This program is composed on many specialist teams trained to meet the most diverse demands of patients and their families. In the PAD program, we have the opportunity to carry out the hospitalization of complex patients who in most cases reside in other states of Brazil. The hospitalization patient is nothing more than ensuring continuity of care and avoiding lack of assistance after hospital discharge. Although discharge to HPN is very complex and can be associated with both immediate and long-term complications, It can be successfully achieved through collaboration between healthcare providers with the institution and the home care company and education of the patient and caregivers. For this process to occur safely, we need to make sure that some criteria are met, such as cyclone PN, clinical stability of the patient, household location, presence of sewage system, tap water, and electrical energy in the environment. Principally, family safe and prepared to handle intercurrent situations is an important point here. Allows 2 trained caregivers, train and qualify home care company, effective communication, and a specialized team offering a remote support. And what are the benefits of parenteral nutrition at home? Why is this so important for the development of the patient and his family? First of all, lower risks of catheter-related bloodstream infections and decreased risk of intestinal failure associated with liver disease. Improve quality of life for patients and their families. Increase survival, social interaction, and reduce healthcare costs. Talking about family participation, families are co-creators of care coordination process and are active central partners in decision-making as members of the care team. Families and care providers work together to build trusting relationships. It's important to increase understanding of the child's clinical conditions, take advantage of strengths, develop the knowledge and skills necessary to achieve the identified objectives, and demonstrate the ability to deal with the clinical, emotional, and technical problems related to home parenteral nutrition and other devices. As important as the family, nurses also play a key role in the patient's hospitalization process. They are responsible for educating the patient and his family even during hospitalization, extending their teachings to the home care company. And how can we define health education? It's a development of critical and reflexive thinking that lead the individual to his autonomy, capable of proposing and giving an opinion on health decisions to take care of himself, his family, and his community. Some points important here. Health promotion, prevention, early recognize and avoidance of adverse events, reduce the patient's time in the hospital and optimize their stay, decrease readmission rates, and ensure quality of life. Effective education of the patient, the caregivers, is an integral part of an optimal HPN discharge. Essential components of the education process should include training on catheter care, dressing chains, infusion pump technology, monitoring for complications and adverse events, and emergency care plan and contact information. And how can we identify this educator nurse? First, we need to know his profile and his technical skill. Then your availability inside or outside your workday. Once this professional is identified, he needs to willing to hold multidisciplinary meetings for alignment, plan his actions, and care for patients, in addition to trained caregivers and home care company. And in practice, how it works. We begin the process of the hospitalization of our patient at hospital admission. We show parents how the health and wellness process works. We understand the fears, concerns, and anxieties. They tell us that they heard from the doctors so many times that their children were going to die. Many times we heard that we are their last hope. Here, it's very important to establish a connection with family and patient. Second, we have a multidisciplinary team with nurses trained to carry out daily training, always respecting the time of family members and the clinical conditions of the patient. We developed our written and individualized discharge plan in writing. In Brazil, the home care company assumes a large part of patient care. However, we also want parents and caregivers to be prepared to be the less safe barrier for these patients. During hospitalization, we will introduce the invasive device, and step by step, we teach them how to handle it and what precautions should be taken, like G-tube, central lines, and other types of device. The idea is precisely to avoid this type of adverse events happen. But if they happen, their caregivers can manage until the arrival of the home care company, or even the need to go to the nearest hospital. Once the caregivers are training and the hospital discharge process is underway, training by the home care company is necessary. The idea is to develop partnership and align care. If necessary, new training can be carried out even with the patients already at home. To ensure continuity of care and close follow-up, we hold weekly telemedicine appointments and monthly face-to-face appointments. In face-to-face, we check anthropometric measurements and laboratory tests depending on the need. Of course, each case is different. That's just the profile of most of our patients. This is our team. Very proud to be a part. These people who allow me to see small miracles every day. We have the opportunity to experience first steps, first words, and first bath with central line, for example. And those little events that motivate us to keep going every day. And to finish this presentation, I'd like to bring the most important key points. For the hospitalization process to take place in the best possible way, we need to attract professionals with the right profile, hold alignment meetings with the local team and with the home care company, being creative and adaptable to the most diverse scenarios, maintain engagement and partnerships between teams and family. And that's all for today. Thank you all for your time. There's my contact. And that's all.
So thank you, Nathália. I think you're going to be being invited to speak again. That was a great presentation. I wouldn't have known unless you told me that it was your first time in English. So thank you very much. I suppose one of the things that when we work internationally, trying to understand some of the local terminology. So when you say home care company, what does the actual home care company do in Brazil for these patients?
A home care company is a company we go to the families at home and take care for the patients, but the most of care like dressing changes, put the parenteral nutrition, doctor, help me.
Yeah, sure. Yeah,
how can I explain this in Brazil?
No, so the thing is, I think we have many different countries participating in here, and each one have a different health system. So here in Brazil, we have public system, and we have insurance companies, and even private patients. Private patients for intestinal failure is very rare because it's very expensive treatment. But when we have an insurance company involved, then we have private third-party companies that we call home care. It's not just the home care as the word, but it's a private company, a third part that is hired by the insurance company to provide care at home. So it's different from many countries where the parents can assume that and do everything by themselves at home. Here we are already moving to that. We have some parents, some teams, I think more frequently in public system maybe, that where the parents are trained to do everything by themselves. But we also have a legislation still on in Brazil saying that this should be a nurse thing. So accessing and deaccessing the line should be a nurse procedure. So we are still dealing with that. So when we here in Brazil say we have a home care, it's not only that we care at home, but also that we have a third part that the insurance company is hiring, and we have to align and deal with them. They have to be part of the team too. So that's why Nathália say we need to train not only the parents, but we need to train this team too.
Yeah, I think just to highlight that that's quite a significant difference between different countries around the world. And sorry, it might have sounded like a weird question, because if you talk about a home parental nutrition company in the US, it's generally a company that hires dietitians and pharmacists and runs the whole TPN themselves. When I was working in the United Arab Emirates, we had the same situation where there had to be a nurse accessing the line. So you had to make sure that they were competent. Whereas I now work in New Zealand and we don't have any external companies. The hospital runs all of the process and the patient is fully self-sufficient with the lines. And I think wherever you are in the world, it's important to work out how all that legislation comes in and how you work in with it to serve your patients the best.
Yeah.
So that's why I bring it up.
Yeah, no, that's a very good question, and it brings up some other discussions, like the burden of having a child like this, very complex at home. It's not something to ignore. So sometimes it's very helpful to have nurses that can go home in specific times to do some process. So changing the dressing, and it's once a week, but it takes some time to do it. You have to prepare everything and so on. And having this other people participating of your daily life, it's also it has a negative side too. So you have people in your home every day, so they kind of like and not like. So sometimes we start with all in, so we have nurses, and sometimes the kid is very complex, so they have overnight nurses staying at home in the beginning, but then after some months they call us and said, I don't want these people here. So we have to deal with that. But also the home care provides them local facilities like physiotherapy, occupational therapists or speech therapists. So we have these companies that can provide other disciplines for them. So it's very important to be engaging all together. What we do, we manage them too. So we are the kind of responsible for the whole care.
So one of the questions that's also come up, and I think leads on to it very nicely, is that you've got these patients with third-party companies or outside nurses, and you've got a very large country. So, how have you developed your telehealth and hybrid care, and especially with nursing care, which is really hands-on? So like a dietitian and a doctor can just sometimes talk about a lot of things, whereas often a nurse has to do lots of very hands-on. How have you used telehealth or, sort of this online system to really improve how you can reach people, Nathália?
Sorry, I think I didn't catch that.
So you when you have patients that live very far away, how are you using like Zoom, telehealth, or online communication to help improve and manage the nursing care when you've got a big distance?
We catch a nurse, especially nurse, and with the telemedicine, we doing a meeting appointment, explain about this specifically child, she particulars and devices and so many things, talking about this family, this routine, if she have a GTub and central line, is I individualize the way. It's
Yeah.
can understand. Yeah.
Can I add some?
Yes, please do.
Yeah.
Sorry to put you on the spot.
It's a little
Yeah.
difficult to me. Yeah.
but it's a fantastic thing that they do at the hospital. So every time we feel the patient is getting ready to go, we figure out which company is going to assume the patient and where, because we're a huge country. And then we get in touch, and then the nurses, they plan meetings and live meetings where they have teaching classes. Sometimes, for example, we can go with we call robots, but it's just a screen. We can go inside the real patient room and do the dressings there, transmitting with them to show them how real life works and how that patient that they are going to receive is used to get the dressing done and so on. And then the mom can know them before be sending home. So it's a very, it's an educational and very important part. They do it. But we use, with COVID especially, we stopped inviting them to come to the hospital, because that's another option. So, oh yes, you come here, travel from your side to come here to see how it is. But we learned with COVID that we don't need that. We can do that using a screen and being on.
We also have a presentation with pictures. We write things and wrote things to doing a compare. And I think this helped the home care company to see the things and doing this at home.
Yeah. And we also send a booklet when we discharge the patient, and they do like a step-by-step. So prepare your materials for PN access, and then a list and what to do, and step 1, step 2, step 3. So if they have a panic moment or some difficulty at home, they can read it. But it's not, I have to say, it's not rare to have a call in like 10 p.m. saying, oh, something happened here, the pump, I cannot deal with that. And then we go live through Zoom usually, or to WhatsApp with them. So someone that is in the hospital, just call them and we do that together. So it's telehealth, it's very useful.
And it sounds like that you've thought of, I think about everything in terms of making sure that the patients have a wraparound care and that they have everything available for any time with information and education and training and support, which is a fantastic effort, I have to say, because in my former job, I developed a home parental nutrition service, and we didn't have a huge nursing input. And it definitely was something that was really challenging to overcome, because it put a lot of pressure on the other team members to take those roles. So believe me, I am really appreciative of nursing. I mean, obviously the doctors, but really appreciative of nursing.
Oh, yes.
Which is great. One of the other questions that we did have was, do you ever use CHIME reinfusion therapy for your NEC patients to facilitate weaning from PN to EN? And that's from Gil Hardy in New Zealand.
Yeah, I know that. Yeah, but actually, unfortunately, no. So CHIME reinfusion therapy, for those who does not know, it's when we get the effluent from the upper ostomy or the fistula, and we can reinfuse it through the distal intestine. And it's a precious thing, because you are usually doing that without reconnecting the patient. Maybe you are in the bad moment, maybe you have a frozen abdomen that you cannot do surgery now, but you can usually wean off more PN, or sometimes all the PM, because we are putting it together so in a different way. So now we have this wonderful devices. This is the Inside company that you can connect. It's a simple, very, very brilliant idea. You can connect in the bag of the ostomy, and it will reinfuse the chyme through the distal intestine of the patient. So it's very useful, but unfortunately, we still not have that here.
And I think it's individualizing the care for your patients, and chyme reinfusion is great for some patients. It doesn't work for other patients. It's the same way you'll choose your central line, based on your patient and their needs, or you'll choose how you're going to follow them up based on a whole, assessment of their patient and their social structures and knowledge. And every patient's so different, I think, with that. So we have a few more minutes, and I just thought I'd ask you a couple of questions. Well, maybe one each. Just what's your greatest challenge with these? What's one of your greatest challenges with these patients? But what is also one of the greatest joys that you have with the patients that you work with?
I go first.
You go first.
For me, this challenge is not to involve. Not to involve too much, because involve is part of this job. And the best thing, and I can see, is miracle every day. We have the opportunity to see first steps and first words, and this is really, really great. I'm so happy to be part of this.
Yeah, I agree with you, Nathália. I think that I gave up of not getting involved many years ago. We get involved, and those are kids and families. It's impossible not to kind of be part of the family, because we are going to be with them for at least 18 years if everything goes right. So this is I think the most challenge moments are the difficult decisions that we have to take in some points of the treatment. So when to do the next surgery, or actually when put back a patient on PM. I hate that because at some point they are very, very stable, and at some point they are growing too fast, and you cannot manage that very easily. So putting them back on PM will actually protect them and allow them to develop very well. So sometimes you have to take that decision too. But the joy of it, and see how they get that life back, and how they really, really live in full. So they want everything. This family wants to go to school. They want one day off PM to go somewhere that they have never been. And so I think they really enjoy life when you get them a good quality of life.
Excellent. And I thought it would just be nice to end on, a really nice positive note about these patients, because you've really highlighted how it's a team effort, that everyone needs to know what they're responsible for, and you need to make sure that every box is ticked and you have it all covered, and then you'll have a really successful journey with these patients and successful outcomes. So thank you for both being passionate in the area and taking the time to present your experiences and the thorough, amazing work that you've been doing across Brazil. So now I'd like to introduce Eliza Francisco. Oh, I've got it all wrong today. I'm bad. To close us up for today.
Okay. So good evening, good morning, good afternoon to everyone. And on behalf of ICNS, we'd like to thank our esteemed speakers, Maria Paula Coelho and Nathália Castro, our nurse, for your presentations today. And of course, thank you to Adrienne Speedy for leading the discussions after. And can I request our host to flash some announcements? Diego. So I'm just going to make some announcements for Aspen. And next slide. So again, thank you, obrigada, and thank you. Next slide. So next slide. For us, Aspen, we just want to remind our members to make use of our online community, which is an exclusive benefit for us, wherein we can participate in online discussions and collaborate on content and share knowledge with the other Aspen sections. So just log in to nutritioncare.org and connect using your member's password. Next slide. And for those who aren't members yet, we invite you to become Aspen members. And among the benefits, we have access to experts, mentors, and peers, and lots of opportunities to grow and to give back by volunteering. We also have subscriptions to JPEN and NCP, special discounts during the conference, and to our discounts on our educational resources. We also have access to clinical guidelines, many academic opportunities and research grants, and awards and recognitions as well. Next slide. And for countries who want to come in as block members, we have what we call the Global Nutrition Partnership Program, or GNP, wherein the countries are classified based on World Bank tiers for low or middle income economies, and we can get special discounts for that if we are able to form at least 10 members in the list for block membership. Next slide. And coming in September, we invite our Malnutrition Awareness Week ambassadors to participate again in this event. And for those based in the US, we're trying to encourage state proclamation for MAO in your individual states. For those who are outside of the US, we will be posting the different activities for MAO Week. Next slide. And feel free to join us on Facebook. Just type in International Clinical Nutrition section, and our administrators will gladly invite you or accept your requests. So this is to keep updated on the ICNS activities. And next slide. So mark your calendar. So this Nutri-Rounds is a monthly event offered by ICNS. So coming in July, specifically July 22, which is a Saturday, our topic would be gut function in critical illness. And we have guest speakers, Farsha Asrani, now based in New Zealand, in Auckland, and Dr. Bhuva Shankar from India. And then in August, we have friends from Aspen ICES, International Clinical Ethics section, to give talks on ethics. And in September, we will have a PN lecture. Next slide. And mark your calendar. So also March 2 to March 5, 2024, the Aspen 2024 Nutrition Science and Practice Conference will be in Tampa, Florida. Next slide. So again, thank you to our speakers and moderator, and also to all the attendees today, and special shout out to our ICNS senior or section leadership team. Our beautiful team members are all on this photo. So this was taken last April in Las Vegas. So again, thank you. Good evening, good morning, good afternoon to everyone. Thanks. Obrigada.
Thank you all.
Thank you.
I just want to thank you, Carol and Diego, especially for the hosting us. I've been seeing you here. That was fantastic.
I need to come to Brazil because I obviously need
Oh
to
yeah, definitely. You
I was
definitely,
unable
you
to
and
speak English
Liza.
at 5 o'clock today, so I was also writing diet histories that didn't make any sense, several hours ago. It just went downhill. Thank you so much, guys.
Thank you very much.
Thank
Bye.
you.